retired medical director of Mercy.
Yeah. I mean, in a sense, I think the question that you're asking is the reaction we have when we have a patient that's having a STEMI that has completely normal labs and they don't have any risk factors, and and that happens to us frequently. I wouldn't be able to put a number on that right now. And then as far as the other medications, I still prescribe other medications that I didn't mention today. I have to defend myself to my colleagues all the time. I am at least appreciative that the ezetimibe and PCSK9s are back in the guidelines for this round as far as niacin. I think I would encourage anyone who wants to learn more about that to read Dr. Saperko's article in the National Lipid Association Journal, I think it was 2017, on perhaps we're not done with the evidence around niacin. He makes valid points that the AIM-HIGH trial was the wrong formulation, dosed at the wrong time of the day in the wrong patient population, and we may have missed the benefits, but there is no trial to help us with that right now, and so we don't know the answer, especially in the era of statins. So. Yes.
If you could just say your name, your organization, and then your question, please.
I'm Terrence Kelly. I'm the scientific lead for the California Stroke Registry for the California Department of Public Health. And my question is around things like obstructive sleep apnea and heart disease. So when you're looking at differential diagnoses and trying to treat cardiovascular disease and hypertension and high cholesterol, does it often, I don't think it often comes up that there's things like OSA.
What's OSA?
Obstructive sleep apnea.
Thank you. This is kind of a no acronym. No acronym zone.
I'll remember that with all of our acronyms at the state too. But I'm just curious, when you're looking at differential diagnoses, are those kind of conditions or things like generalized anxiety disorder that can increase hypertension levels often looked at, or do you think they're overlooked at all? Just curious.
I'm sure. I think that the hypertension guidelines are written not to look at hypertension in isolation, and we certainly look at the comorbidities, often hypercholesteremia. The items that you just mentioned are well documented in the algorithms to look at treating and identifying causes for hypertension. So as part of the lipid guidelines, sure, there is the known situation where you have somebody who's not getting good sleep and their lipids and their hypertension are difficult to treat. I don't know that it may have been in some of the finer items of the guidelines. I don't recall seeing it. So. But I think that we address that perhaps through the hypertension components of the guidelines. So. Yes?
Do fibrates play a role at all in using guidelines, or kind of like niacin, are they pretty much left out?